clinical trial, but that is non-compensated to myself. I was a former consultant to Allergan up until 2015. And I want to take us back in time because every story starts with the very first day. And this one starts in the state of Washington, where two best friends, a plastic surgeon and an oncologist, came together over a beer and talked about an interesting case they had, and for the very first time described breast implant ALCL. Shoot forward 22 years, and on July 24th, 2019, the FDA takes action and calls for a Class 1 device recall of Allergan BioCell implants. Now, as we will see over the next 30 minutes, I would argue that this decision was expected and it was evidence-based. And we'll go through some of that data up until this point. If we look at the last year in device regulation, we see that Egypt was the very first one to restrict textured implants in July of 2018. And then a number of different government authorities, as well as investigative journalists, came out with views on breast implants. We started to see companies or countries restricting the sale of Allergan BioCell, starting in December 19th. And then we had our government authority advisory hearings in February and March, the most recent one from the FDA. France suspended macrotextured implants on April 2nd. The US at that time, after 38 countries around the world had restricted BioCell sales, said that Allergan did not meet the banning standard, but a number of subsequent companies went against that decision, and ultimately the US would reverse course and ask for a Class 1 device recall of Allergan BioCell. And Allergan immediately recalled BioCell worldwide. We have seen another decision since then, just a week and a half ago. The TGA of Australia banned macrotextured implants, which affected 8 manufacturers. You can see that this decision by the FDA was based on updated and cleaned up data from the MOD database. Instead of referring to their data as incomplete, inaccurate, and potentially biased, they now refer to them as unique and pathologically confirmed, 573 cases. And you can see how they previously broke down. There was a large jump in worldwide death cases from 9 in March to 33. For the very first time, they actually reported manufacturer. And they've been asked by manufacturer in past years, but we finally see it revealed in July 24th. We can see that of the worldwide cases, 91% were Allergan or involved Allergan when the device was known. Because of this, we also saw a number of cases around the world. We have formed a global network roundtable around the world of 33 countries, and this information is updated as of this week. And you can see we see 511 outside of the United States world cases. We see 164 confirmed cases in the United States, still 138 that are under investigation right now. But if we look at this, this comes to about 680 worldwide cases that are definitely unique, pathologically confirmed, and met the World Health Organization criteria for the disease, as well as 33 deaths according to the FDA. We do see that Allergan has an overrepresentation when compared to other devices around the that are publicly available, anywhere from 8.1 to 32 times higher than the next manufacturer. And it was because of this information, as well as Allergan's own prospective series from their CARE trial of 17,656 patients finding 8 ALCL cases, creating a risk of 1 in 2,200, that the FDA made their decision to restrict sales of Allergan BioCell. I think it's important that this CARE trial was prospective. This is the only level 2 evidence that we have on breast implant ALCL in a large population. We see that Australia has been reporting manufacturer-specific risk, and we have Anand Deva speaking to this later on, but he's quoting a risk of 1 in 3,300 for Allergan BioCell and a 25-to-1 ratio between BioCell and Allergan Celtex. We see other countries reporting, and we'll hear from them later, and we can see how that breaks down by country. TGA did restrict sales of macrotextured implants just a week and a half ago. This did affect 8 manufacturers, but importantly, it did keep on the market Mentor Celtex as well as Allergan BRST being microtextured implants, though it did increase the number of study requirements based on those implants. This was important because within the Australian marketplace, they don't have access to smooth implants. And therefore, this was important to keep some kind of options for breast reconstruction patients, breast patients in general. If we look at what TGA in Australia restricted, they have used the Jones-Diva classification, which is the fourth one over, and they specifically restricted grades 3 and 4 macrotextured implants. Most government authorities use the ISO classification, which is the first column. We see a number of texturing classifications. I can say that we are aware of no cases in the top row. Nearly all of the cases are in the bottom row, exponentially higher than manufacturers in the middle row. But we don't have any of these that are actually validated prospectively clinically. The FDA very importantly clarified that there are no pure smooth implant cases to date. There had been some miscommunication with their March and their May updates, but they clarified that, stating that if there was a smooth case within their database, it had a prior clinical history of a textured device or no clinical history available. It's very important. I see frequently people cite the FDA as saying that there's smooth cases, but there are not, and they have clarified that. Recommended by the American College of Surgeons and the FDA is the retroactive notification of Allergan BioCell patients. And we see a number of institutions, Penn State being the first one to do that years ago, and Dr. Donald Mackay will speak to that today. But I will point out, no Plastic Surgery Society makes this recommendation. Despite it being a Class 1 recall, the FDA does though say that these patients should be alerted. Risen in the last several years since 2017 is the National Comprehensive Cancer Network guidelines on this disease. First started as the MD Anderson algorithm, then becoming the American Society of Plastic Surgeons algorithm, and now NCCN guidelines algorithm. We can see that this was updated in 2019 to get the reliable diagnosis, and we'll have Dr. Roberto Miranda speaking to that. We also see the treatment of the disease is surgery in the vast majority of patients, and that advanced cases are the only ones that usually require chemotherapy, ideally with targeted immune therapy. So how do we differentiate a benign seroma from a ALCL patient on the bottom? Well, I think it's critically important that we're comparing apples to apples, and I worry that surgeons are seeing the top picture with a couple of inflammatory cells which happen to stain for CD30 and calling that ALCL. That is normal, and 1 to 5% of circulating lymphocytes can express CD30. Confluent stain, CD30 on the bottom, with large anaplastic cells and a single T-cell clone, that is ALCL. And we'll speak more to this later, but that's critically important that when we're reporting cases, they meet World Health Organization classification, and that we're not seeing anybody with inflammation and mislabeling them a malignancy. I talked about the 3 criteria, CD30, as well as large anaplastic cells, as well as a single T-cell clone on flow cytometry. Once we have this diagnosis, we do disease workup with a PET CT scan, which is critically important to look for disease spread and metastasis. As you can see, an internal mammary lymph node lit up in the PET scan. We see 4 countries around the world reporting their stages of disease by a TNM staging system. And by this, in an ideal situation, surgery could treat 85% of cases. That is ideal. That is our wish. That is not actually happening. We see about 60% of patients getting chemotherapy, 45% getting radiation therapy, 7% getting stem cell transplant. But ideally, we could treat 85% with surgery alone, and that is our goal. Surgery should be a en-bloc resection, which is an oncologic procedure, and as you can see, the resection of that mass requires a healthy rim of margin of tissue around it to make sure that it's completely excised. I want to define some key aspects. When might a partial capsulectomy be done? Here I'm doing it for capsular contracture with radiation therapy. I do a total capsulectomy for a double capsule. Notice it might come out piecemeal, in pieces, buttonhole. Sometimes it can be seen as incomplete. However, an en bloc resection is an oncologic procedure that is performed for cancer. This includes explantation, capsulectomy, ablation of associated masses, as well as a rim of healthy margin. And I think that there's been a co-opting of this term for patients that don't have the disease. Again, en bloc resection is a cancer resection procedure, and it's really only indicated for a cancer. And you can see the aggressiveness of what an en bloc resection looks like. And this, more importantly, is what it looks like after that en bloc resection. And what you can see in the video moving up and down is the lung. Frequently, the intercostal muscles will actually come out with the capsule when it's resected. And you would never, ever want to do this to a patient that doesn't have the disease. Within our series that we published on en bloc resections, we had a 4% pneumothorax rate. 4%. We estimate that approximately 3 million patients in the United States have textured implants, and to prophylactically do these procedures puts patients at harm needlessly. We put this video together just demonstrating the salient points of an en bloc resection and the presentation of what a patient looks like. So this patient presents with a large delayed effusion of the left breast. We're utilizing skin incisions that have already been made so as not to further devascularize the skin. And you can see in a patient with a previous nipple-sparing mastectomy, a total capsulectomy can result in complete necrosis of that overlying skin. So you want to be careful. Here we're using tumescence to establish a oncologic plane to actually be able to do a complete sharp dissection of the procedure. Here you can see a rim of healthy tissue coming out with that specimen. And you can see how aggressive these procedures, frequently stripping periosteum off of the rib cage, particularly when the implant is behind the muscle. This is an aggressive procedure, feels very much like a mastectomy when it comes out. And so therefore we reserve this for only diagnosed patients. Here it is in pathology when it's actually coming out. This does not usually look like a normal breast being removed, highly fibrinous, can have necrotic debris as well as tumor tissue. In the next video, you can actually see a 16 centimeter mass being split as it was on the inside of the capsule with a Allergan 410 implant sitting in the backside. And it's incredibly important that you appreciate these masses preoperatively so as not to cut them in half afterwards. Complete resection is absolutely critical for the diagnosis of this disease, and we have seen patients that have been explanted and then still develop the disease. But I also want to point out that we've seen patients get total capsulectomies for capsular contracture years prior and still develop this disease. So I don't believe in the idea of a prophylactic capsulectomy. I'll repeat that. We have patients that received capsulectomies, total capsulectomies for other indications, and still develop the disease years later. And so I worry about this rising idea of a risk-reducing procedure, which there's no data to support at this time. We can see in the patient that had incomplete resection and had a deep flap reconstruction. The deep flap was unfortunately set right next to an ALCL mass, and she would present just a couple months later with widespread bony metastasis. We were able to get complete remission in this patient, but this disease is indolent, it's slow growing, except when cut in two. And when cut in two, it seems to manifest the oncologic phenomenon of hyperprogression. It actually advances and grows faster when you do that. For patients with unresectable disease, we do recommend targeted immune therapy with brentuximab. As you can see, complete remission after just 2 rounds of brentuximab. Because of this, brentuximab CD30 targeted therapy is the preferred first-line treatment for breast implant ALCL by NCCN guidelines. However, deaths are rare, 33 to date, and they usually represent a delay in treatment or under-treatment. These are not historical long ago. This one was 2 weeks ago. And I just want to bring this up to show you that these are still happening. This is from a major cancer center in the United States, and the patient expired 2 weeks ago. Delayed seroma presentation, not initially checked for CD30. She progressed to supraclavicular lymph nodes, axillary lymph node metastasis, and chest wall invasion. She was treated with bilateral capsulectomy and brentuximab combined with CHOP. However, she advanced on brentuximab. This is actually our second advancement on brentuximab. I want to point out a study that I collaborated with Roberto Miranda on PD-L1 expression of ALCL, and he looked at 34 patients and found 88% expression of PD-L1. PD-L1 can be treated with nivolumab. The data that I just showed you demonstrates that we need clinical trials in these advanced cases, and I would actually offer that I think that we need to do a multi-center prospective phase 1 study of brentuximab combined with nivolumab to actually make sure that we have complete efficacy and we don't lose patients like that last one I just showed you. Now, at MD Anderson, we formed a U.S. centralized tissue repository based out of MD Anderson, where we have tissue specimens of over 100 patients, and these are just some of the collaborations. You'll be hearing from about half of these collaborators today. This is one that we did with Andrew Feldman at Mayo Clinic. We actually looked at 36 cases of ALCL and found that they were genetically distinct from all other types of ALCL, and very importantly, they had 100% STAT3 expression, as well as they were mediated by JAK1, STAT3, and P53 mutations. What's important about STAT3 expression is that STAT3 is a transcription factor. It's overexpressed, it promotes tumor progression, and it also suppresses anti-tumor immunity, drives inflammation, and prevents cancer differentiation. And it's 100% expression in these patients. This is a key aspect of the pathogenesis. Also, the idea that JAK1 and STAT3 are spontaneous mutations, that means that that is not a genetic predisposition. But TP53 is, because it's a germline mutation. Patients with TP53 have Lee-Fraumeni syndrome, and there's now 4 case reports of ALCL arising in Lee-Fraumeni patients, making for the very first time a genetic contraindication to a textured surface breast implant. Also, in a collaboration with Dr. Feldman, is the idea that BI-ALCL demonstrates what we call a hypoxia environment. It requires hypoxia. So Dr. Feldman genetically sequenced 25 ALCL patients and compared it to 48 non-ALCL patients. And interestingly, he found CA9, previously found in renal cell carcinoma, was present in all of the ALCL and in none of the non-ALCLs. CA9 is important because it silences cell growth, and it also was detectable in the serum. So for the very first time, we potentially have a blood test for breast implant ALCL. Dr. Anand Deva is going to be speaking to the idea of biofilm, but in this collaboration from 2016, we brought up the idea that it could be mediated by Rostonia. Rostonia has fallen out of favor as it has not been seen in a number of cases since this manuscript was published. And Dr. Deva will be updating this biofilm theory. I will point out in a manuscript a month ago in a collaboration with Terrence McCann at Washington University, we looked at the microbiome of ALCL, and we actually found that it was the same as capsular contracture. It was the same from the left breast to the right breast in an ALCL, and it was the same to normal patients that did not have the disease. So these patients do not have distinct microbiomes. They look just like gram-positives that you would expect with any patient. However, some physicians have advocated the idea of using anti-infective technique. And this study supposedly was a prospective series started in 2003, 14 years to look at ALCL for a technique that was first described in 2013. Because of that difficulty with that study design, we actually looked at can technique actually predict for ALCL? When we look at the FDA database and the MD Anderson database, we see an even split between reconstruction and augmentation. Yet we know augmentation has an infection rate of about 1%, and reconstruction has an infection rate of about 9 to 14%. Reconstruction is a much more contaminated procedure, yet it does not have a higher rate of ALCL. In fact, there's more augmentation patients. We've also looked at operative strategy, and we can see anti-infective technique was used in these patients. 14-point plan, oral antibiotics, all of these were utilized in ALCL patients, and yet they still developed the disease years later. So we don't see operative strategy being able to decrease risk of ALCL. We've also looked at the effect of ADM on the development of ALCL, and we see that about 7% of ALCL patients did have ADM at some point. I will point out that there is no case to date in a circumferential wrap. However, that is a relatively new procedure. There is no case to date where the tumor actually developed in the area of a mesh, and so we still need to see if there is any protective effect, if it can actually be a block between the skin as well as the implant, and we need further research on this subject. What I've seen described more and more just in the past 6 months is a concept of clusters of ALCL. I actually recognize about 18 world clusters around the world, and that's with 2 or more cases being reported by the same surgeon. But what's important is that a lot of those are referrals to a surgeon that's just interested in the disease. When we actually look at surgeons that actually had personal cases, we only see 5 world clusters around the world, where a surgeon, exact same surgeon, had multiple personal cases. And I want to point out that of these, 4 of them were actually frequent speakers on proper breast implant safety and published extensively. All 5 have actually previously done studies on breast implant ALCL. Practice data was available from 3 sites and confirmed that there was no break-in technique or sterility, and that all incorporated anti-infective strategy. Now, they do represent mature implant practices with 5,000 plus implants. They follow strict follow-up regimens annually, seeing their patients every year. 2 of the practice follow MRI and ultrasound every 2 years. Why is this important? We actually surveyed 824 ASPS members last year. This was a study out of Penn State by Logan Carr, and he actually found that about 34% of plastic surgeons only followed their patients for 1 year, 42% up to 5 years, and only 24% up to 10 years. We actually look at who follows their patients greater than 10 years with MRI and ultrasound regularly. There was only 3% of American plastic surgeons. What I'm just telling you is that the clusters represent less than 3% of practices. Clusters are disease awareness. Clusters are heightened surveillance. Clusters represent long-term follow-up of their patients. And yet I am worried when I do see that some physicians are claiming that clusters represent poor technique. Clusters mean that they didn't know how to place the implant up front, and that's why they got that complication. I would actually say that these physicians are demonstrating the kind of follow-up that we need to have on our patients, and I worry that misattributing clusters to poor breast implant technique will have the negative effect of discouraging the reporting of cases. US and Canada prefer smooth implants. We're an 87% smooth implant market, and actually as of March, the FDA said that that had been about 5%. We still see about 3 million textured breast implants still though in the US circulation. And in my own practice, I started with smooth implants. I enjoyed textured implants. They slowly trickled off, going to about 0 in 2017, corresponding to my research on ALCL, and after treating 64 cases, I no longer use any textured devices, tissue expander, or implants. I like my outcomes, and these are smooth implant outcomes. About half of them have been fat grafted, half of them haven't. These are round, smooth implants, and I think that while this is common in the United States and Canada, this does need to be said within a European forum, is that reconstruction, we can get nice results still with a smooth implant. I've included unilateral, bilateral, skin sparing, nipple sparing, radiated, non-radiated, just to demonstrate that outcomes can be very good with a smooth round implant. I would encourage reporting of data in the United States. We have the profile registry updated as of this week. 301 cases have been referred over to the profile registry. And the idea, Colleen McCarthy is the principal investigator, and she hopes to actually do annual reports. We saw the very first one in March of this year, and she hopes to have another one next year. And we reported a number of firsts with this manuscript: the very first black race case, the very first incidental finding, the time of mastectomy, and 2 bilateral cases. I'm aware of 11 bilateral cases to date. And when the clone was tested between the 2 sides, It appears that it was two separate primaries, so we still treat these as two separate primaries, not as metastatic disease. ASPS frequently asked questions are available. This was just released on September 25th, and it has both patient-facing and physician-facing questions, specifically speaking to the FDA decisions. We also published in two separate journal supplements in March 2019. 55 authors, many are here today, came together to do 16 peer-reviewed manuscripts on breast implant ALCL. These are the PRS manuscripts on the disease. These are the aesthetic surgery journal manuscripts on the disease. And these manuscripts all were timed to correspond with the FDA hearings in March. I think that it's important that two journals that are known for competing against each other came together to actually do this simultaneously, because they realized that this information needs to come out. I also point out that these journals were actually supported by many of the manufacturers that supported this conference today as well, and I want to thank them for that. So advances in detection now offer novel and low-cost screening options for breast implant ALCL. Genetics data, importantly, has now provided novel targets for advanced stage disease. NCCN guidelines are the standard for the diagnosis and management of breast implant ALCL. And as you can see, with so many new slides just within the last few months, increased international regulatory scrutiny has created a rapidly changing climate. I also want to take this opportunity to invite you to Houston, Texas next year on November 7th. We'll be having the second World Conference on Breast Implant ALCL, housed at MD Anderson Cancer Center. And I'm very excited to bring all of you, hopefully, to Houston, Texas, to the largest medical center in the world. I also would be remiss if I did not thank our patient advocates. Some of them are here today. I think that these women are the real face of this challenge. They have given us lessons in strength. They have taught us things that the data can't, such as financial toxicity. How much is the financial toll, the physical toll, the family toll? They have showed us the importance of shared decision-making when we're giving our informed consent, and very much they are the driving force for change. I also want to thank my multidisciplinary team at MD Anderson. Some are here today, some are not, and hopefully will be here next year. These individuals have produced 47 manuscripts over the last decade on breast implant ALCL. They include 11 different departments at MD Anderson, over 3 different divisions. We have actually a major part of the MD Anderson Rare Tumor Initiative. We have major support of our entire institution, and we could not do that without that support. I want to end there, and thank you for coming today.